It is common knowledge in medicine that despite all the major advances over the past century, injections, or the shot as it is commonly referred to, are still being performed the same way they were when initially described in the late 1800s. The limitation of fear, pain, and lack of ability to precisely locate needle tip position when performing an injection is well understood. The only way to truly overcome the deficiencies of the past systems would be the development of a system that could precisely not only control flow rate, but more importantly control pressure of a drug when performing an injection. This insight led to an innovative technology that could determine the pressure at the tip of the needle, which I termed exit pressure. A complex algorithm was created so that if different disposable components were used, such as different needle gauges, syringe sizes, or drugs with different viscosities, we could account for these changes and we could still precisely measure pressure at the needle tip. In addition, we enabled exit pressure to become the controller of the delivery system. We can differentiate types of tissues, the location of the needle within the body, and thus identify a specific anatomical target with a new source of information we never used before: pressure measurements. We call this technology a dynamic pressure sensing technology. This is the beginning for this concept, and I believe we are now ready to bring all types of injections into the digital age to advance the art and science of intra-tissue drug delivery for our patients.
So now we can track the location of a needle within tissues having different densities. And this is exactly what we as anesthesiologists do every time we perform an epidural block using our subjective feelings of loss of resistance. But let us now continue to watch the video.
This medical instrument consists of the primary unit with an LCD screen and an optional pneumatic foot pedal control. The instrument requires a sterile, single-use epidural disposable kit, which includes a 20 ml syringe, a tubing set, a pressure sensor, and an adapter key. The instrument can work with all standard, currently available epidural needles. The instrument uses an algorithm to determine the pressure at the tip of the needle via a continuous fluid path. An audible and visual graphic of exit pressure is provided to the physician, enabling the operator to focus on the injection site. This system is unique in that pressure is a feedback loop and controller to the system, thus regulating the electromechanical motor which controls the flow rate and the fluid dispensed by the system. Currently, healthcare practitioners rely on their subjective perception to feel a loss of resistance when inserting an epidural needle to identify the epidural space. The Compuflo Epidural instrument allows objective pressure data and the use of a bilateral manipulation of the epidural needle. The zero pressure calibration is made, and the instrument is set to deliver normal saline at a rate of 0.05 mils per second, with a maximum pressure threshold of 120 millimeters of mercury. After skin local anesthesia and after its subcutaneous insertion, the epidural toy needle is connected via an arterial pressure tubing to the Compuflo in order to register the delta of pressure encountered by the needle during its advancement. Entry into the epidural space results in a sudden drop in pressure on the visual display, as well as a distinct fall in the tone of the audio output. The operator immediately stops the procedure and observes the graph. A sudden and sustained drop greater than 50% of the maximum pressure and found to form a low and stable plateau for more than 5 seconds is consistent with entry of the needle into the epidural space. After these 5 seconds of stable plateau, the pressure in the epidural space may also be recorded. After the final epidural pressure reading, the Compuflo is disconnected from the toy needle and an epidural catheter is inserted for the intended use. The Compuflo Epidural generates a treatment record by recording pressure values, fluid volume, and flow rate 4 times per second. The data can be reviewed or transferred for further analysis after completion of the procedure. This is the typical pressure display during the identification of the epidural space with Compuflo. Start of fluid flow. Increase in pressure when the needle constantly advances through the tissues. When a sudden drop in pressure occurs, it is important to immediately stop all needle movement and to observe the behavior of the pressure within the tissues. In this situation, the pressure rises rapidly again without needle movement. This indicates a false loss of resistance. This typically occurs within 1 to 3 seconds. Needle movement begins again. The needle is advanced. The entrance of the needle tip in the ligamentum flavum is perceived through the tactile feel of the operator as an increase of resistance to the needle's constant and interrupted advancement. In this case, the Compuflo displays a high pressure threshold, as well as a dramatic increase of pitch to the audible tone. When a sudden and profound pressure drop occurs, all needle movement must be stopped. A new lower stable constant pressure plateau lasting at least 5 seconds, accompanied by a decrease in the pitch of the audible tone, will indicate that the epidural space has been identified, and this is a true loss of resistance. Therefore, Compuflo may differentiate the differences between a false and a true loss of resistance. A sudden and sustained drop, greater than 50% of the maximum pressure, and found to form a low and stable plateau for more than 5 seconds, is consistent with entry of the needle into the epidural space. If these criteria are not fulfilled, such as a small increase of delta of pressure followed by a slight transient drop, the result may be considered as a false loss of resistance, and the epidural needle may be further advanced or repositioned until a true loss of resistance is obtained. Compuflo may also be employed in the case of combined epidural spinal technique. By using our specifically designed epidural simulator, we are able to see the spinal needle puncturing the dura after the epidural toy needle, assisted by Compuflo, has been located in the epidural space.
My colleagues and myself conducted the initial pilot study at the University of Texas using the Compuflo Epidural instrument for epidural space identification. We found that the Compuflo Epidural instrument was successful in identifying the epidural space in all of our patients. And in addition to that, we also found that Compuflo Epidural instrument actually could tell us which structure we were passing through on the way to the epidural space. For example, the ligamentum flavum or the interspinous ligament.
Initially, when I began to use Compuflo, I was a little afraid of performing the puncture, losing the usual sensations that come with a low resistance syringe. But I quickly realized that the correlation between the advanced needle with the 2H needle and the images and sounds of Compuflo are very reliable.
The first thing we did was to validate the instrument. We performed a prospective blinded study to evaluate the inter-rater agreement between an expert anesthesiologist and the Compuflo recordings in pregnant patients. All increases or decreases of resistance were compared with the Compuflo recordings blinded to the operator. There was a very good level of concordance between the operator's tactile feelings and the delta pressure recorded by the Compuflo, with regard to both the identification of the ligamentum flavum and of the epidural space.
Compuflo is a new and novel device to identify the epidural space. It is a very easy tool to identify the epidural space, the ligamentum flavum, and a bony contact you might encounter during an epidural procedure.
The most experienced anesthesiologists will obtain benefits in difficult punctures, obesity, edema, anatomical alterations, etc.
I believe that it has beneficial effects in terms of teaching your trainees to let them see the difference between normal tissue and the epidural space where there is reduced pressure. So I feel that this device holds big promise for teaching purposes and also for common routine practice.
We also performed another study with our epidural simulator comparing the Compuflo pressure curves obtained with the simulator with those obtained in humans for consecutive laboring parturients requesting epidural analgesia. The epidural simulator and human pressure curves were very similar. Compuflo was able to differentiate the dropper pressure due to the false and true loss of resistances not only in humans, but also with the simulator. And this means that Compuflo can be used to teach trainees epidural block with the simulator.
The practice of epidural anesthesia has not really changed in the last 100 years. The operator relies on the subjective feeling of loss of resistance, basically perceived with his hand. The Compuflo epidural instrument, on the other hand, gives you an objective way of identifying the epidural space. We can now see when the needle reaches the epidural space on a graphic display, and we can also see a pressure drop, which is objective. And in addition to that, we also get an audible notification once the epidural space is reached.